A very warm welcome to everyone. We are HART Fertility Clinic. We're based at the world-renowned Christian Barnard Hospital in Cape Town's foreshore. We're a full-service fertility clinic offering all fertility treatments from artificial insemination to IVF and egg donation. We welcome Dr. Victor. Dr. Victor is a specialist gynecologist and obstetrician who is passionate about high-risk pregnancy care and obstetrics and fertility treatment in women. Dr. Victor, can you tell us a bit about yourself?
Morning, Kenny, and thank you for the opportunity to join you guys on this meeting today. Yes, I am a mom of 3 little ones who were all 3 conceived by IVF themselves, and obviously there my journey with infertility treatment started, and that's I think the area or the time when I fell in love with infertility myself. So being an obstetrician and gynecologist, I worked in Cape Town for 15 years and desperately wanted to do infertility, and then we left South Africa and went to Mauritius to go and do fertility treatment there. I worked in an infertility clinic for a year, but then we missed South Africa tremendously and we wanted to come back. And I am now working at St. George's Life Hospital in Port Elizabeth. I'm doing general obstetrics and gynecology, and then with a preference in high-risk obstetrics, as well as infertility.
Okay, thank you. So our topic today is when to have a fertility assessment. So Dr. Victor, what is a fertility assessment?
Okay, so basically a fertility assessment is to investigate to see if you can have a baby or why you are not falling pregnant if you are trying. So we typically have 2 types of patients who come and see us. Firstly, the group who decide, okay, we are ready to have a baby now, and that they want to just come and see us to make sure that everything looks okay, so that they can get the green light to go ahead. And then those patients who have been trying for a while and nothing's happening and they want to know why. So that's basically to see what we can do to try and help you conceive.
Okay, so who should be going for a fertility assessment, or does every female need to undergo one?
I don't think it's necessary for all females to go for a fertility assessment. We actually say to our couples, depending on your age, if you are younger than 35, we recommend a year of unprotected planned intercourse, maybe tracking your menstrual cycle and ovulation. And if after a year you haven't fallen pregnant, then to seek help or advice. Patients older than 35 should not wait that long, maybe only 6 months before they can go for advice. And then if you have a pre-existing condition and you're aware of that, like for instance endometriosis or polycystic ovarian syndrome, and you know that, and you want to now start trying, maybe just to go and see somebody to make sure that everything is optimal before you start trying.
Okay. And is there a perfect time to come in for an assessment? Like, do I need to take my cycle day into account before booking my assessment?
Yeah, it is obviously always difficult with a gynecologist to plan exactly, because you never know where you're going to get an appointment. But it is ideal for us to see the patients in the first half of their menstruation cycle. The reason for this is in the first half of your menstruation cycle, your ovaries are preparing for ovulation, and we can then evaluate the ovaries properly to see if there are little follicles developing, and to see if your endometrial lining is normal. After ovulation, your endometrial lining starts breaking down if you're not pregnant, and that then makes it very difficult to see pathology in the endometrium and for us to know if you ovulated indeed. So first half of the cycle is always the best, preferably not on your period for the examination itself, because it makes it a little bit difficult to evaluate. It is ideal though to do the blood tests for the evaluation within the first 5 days of your cycle. So if a patient is being worked up, we try and send them for their blood tests from day 1 to 5 of their cycle, because that's a way for us to standardize where the hormone levels should be. But if you just want to go and talk to your doctor any time of the cycle is a good place to start.
Okay. And what exactly happens at a fertility assessment?
So first of all, your doctor is going to ask you a whole range of questions regarding your menstruation cycle, around your sexual health, your partner's health, any medication that you're on, any of the endocrine systems that might be involved in infertility. You'll be asked questions regarding that. Sexual health, if you have painful intercourse, if you know if you're ovulating, those type of questions will be asked. And then a pap smear will most probably be done if you haven't had one recently. And then a transvaginal ultrasound will be done to evaluate the internal sexual organs, the uterus, the ovaries, the fallopian tubes, if there is major pathology. And according to what the doctor then finds, further investigations might be necessary. So if the doctor finds, say for instance, signs of an endometrial polyp, you might be booked in for a hysteroscopy. If the doctor is worried about signs of endometriosis or an ovarian cyst, you might be booked in for a laparoscopy. Some patients are sent for an MRI to see if there is, say, for instance, fibroids that needs to be removed. But it depends on what the doctor finds from the history and the physical examination.
Okay. What's a hysteroscopy and how often are those done or prescribed?
Well, in patients who struggle with infertility, hysteroscopy is almost probably one of our most used tools. And hysteroscopy is a small little instrument that we put through the cervix into the cavity of the uterus, which we can then inflate the uterus with some fluid so that we can see on the inside. And we can then diagnose polyps, fibroids bulging into the cavity, abnormal blood vessels, abnormal tissue, maybe a septum in the uterus. So this little camera is about the size of a half a pencil. So it goes through the cervix into the cavity of the uterus, and we can then have a look on a screen to make sure that we see the pathology and then treat it at the same time. So if we see a polyp, we can remove it. If there's a fibroid, we can remove it at the same time. And why we need to do it in the first half of the cycle is your endometrium is quite thin at that stage, and it is then easier to see the pathology at that stage. Okay. So it can be done in a day hospital facility. Some doctors do that in their rooms. I know overseas it's done quite often, like they call it an office hysteroscopy. But in South Africa, we tend to do it under sedation or in theatre. And it's just a day case, and it's not painful at all.
Okay. You mentioned an MRI earlier. What can an MRI tell you?
So especially in patients where we have fibroids, we want to see exactly where those fibroids are located to see if it will interfere with your fertility. We are specifically interested in fibroids that presses against the endometrial cavity, because those can definitely interfere with falling pregnant. And especially if we want to plan surgery. So we call it a MRI for fibroid mapping. And then the radiologist can tell us exactly where these fibroids are so that we can then plan surgery. Okay. So that's regarding fibroids. We can sometimes see patients with endometriosis, large pockets of endometriosis between the uterus and the rectum. Also, once again, for planning our surgery. Abnormal pathology on the ovaries, if you may be worried about a tumor, if you think it might be benign or malignant, then we obviously try and evaluate it according to the MRI as well.
Okay. And are there any blood tests? You mentioned earlier that there are blood tests that patients go for.
So you basically have 5 hormonal systems that all work together to that reacts with each other to control your fertility and your female hormone cycle. So we have to investigate all 5 of those hormonal centers. So basically your female hormonal system, your adrenal gland system, your pancreas secreting hormones, your prolactin and your thyroid. So your prolactin is a hormone that's secreted from your hypophysis gland in your brain, and this can influence your ovulation if it's abnormally high, and then your thyroid. So we basically investigate all 5 of those systems by doing blood tests. Your female hormones, the LH, FSH, the 2 hormones secreted from your brain, should be in a ratio of 1:1 in the first couple of days of your cycle. And if it's not in that ratio, it can give us a good idea of pathology. And then I also send my patients as part of the workup for a profile, which we call the antenatal profile, which we usually actually only do when the patients are already pregnant. And that includes your blood group, hepatitis B, immunity against German measles or rubella, HIV, and a sexually transmitted disease screen. So while we're busy doing the workup for infertility, we can just as well make sure that those things are already in place as well, so that if there is something wrong, we can treat that before the pregnancy starts, so that we have a better outcome at the end of the pregnancy. For instance, if you are not immune against rubella, we can inoculate you before you fall pregnant so that you cannot get it during the pregnancy. If we know that you have a negative blood group, we can salon test your partner's blood group, make sure that you don't have antibodies. So for me, that's quite important to do that at an early stage as well.
That makes a lot of sense. If I don't have rubella immunity and I need to be immunized or vaccinated, how would that delay my treatment, or would I put off before pregnant?
Yeah, it's a live vaccine that we actually give the patient, so it's as good as we're giving you rubella. And rubella is a teratogen for pregnancy, so the babies can get abnormalities if you inoculate the mommy and she falls pregnant within the first 3 months. So we always say inoculate and wait 3 months before you try and conceive, or then go for a fertility treatment.
Okay. So we've had a question come through. What is AMH and E2?
Okay, so anti-Malarian hormone is a hormone that we can do at any time throughout your cycle. You can even be on the pill when we test for this. And this just basically gives us an idea of your ovarian reserve. So basically, in layman's terms, how many eggs do I have left? Or how will I respond to fertility treatment? So a patient of, say, for instance, 42 years old, who doesn't have a very long fertile lifespan ahead of her, will have a lower anti-Malarian hormone than, for instance, a 16-year-old that's 100% fertile. So we always use this as an indicator of how urgently we must send the patient for fertility treatment, and how well will she respond to, say, for instance, IVF cycle. If her AMH is really very low and we know that she's not going to respond that well, it will also give us an idea of what type of medication to use for the IVF cycle. So I routinely do it on my patients before I send them to the fertility clinic, just so that the fertility clinic knows what we're working with. To give you an idea, a patient that is menopausal, for instance, will have an anti-Malarian hormone that's undetectable. A patient with polycystic ovarian syndrome, for instance, that has multiple little follicles sitting in her ovaries, which is part of her pathology, will have a very high anti-Malarian hormone. So although she's not falling pregnant, we know that there's a lot of egg reserve in that ovary. E2, estrogen, is one of the hormones that your ovary secretes to build up the lining in the first half of your cycle. So it's basically our female hormone. As we get older and as we turn menopausal, your estrogen levels fall, and it's the hormone that basically prepares your uterus and lets your lining on the inside, your endometrium, grow to make it ready for implantation or receiving of an egg.
Okay. All right. So those are all the baseline tests that you would send your patients for,
Yes.
based on the outcome of their scans.
Yes.
Okay. And what are the approximate costs for these blood tests?
I actually got a quote from the laboratories for us. The thyroid hormone, the TSH that we use, is in the vicinity of about 400 Rand. Your LH, FSH is about 250 Rand each. Your prolactin is another 250. The most expensive one of them all is the anti-Malarian hormone, and that goes for about 1,000 Rand. So if you look at the whole basket, we're talking about quite a couple of Rand if we need to do that. The full fertility blood workup, plus the antenatal screen, which is your blood group, hepatitis B, German measles. So it can very easily add up to about 4,000 or 5,000 Rand.
Okay, but it's worth, based on everything you've said, it's worth spending that money on it so you can establish
definitely
where you sit.
Yes, and I always say to my patients, it's not necessarily necessary for you to go and see a IVF clinic if we do the basic screening bloods here and we see that, but it's a thyroid issue. I can start you on thyroid medication and then you start ovulating and you don't have to go to the fertility clinic. So I think for us as general gynecologists, the basic workup can very often help the patient fall pregnant before she even goes to see a fertility clinic or a fertility specialist. So it's worth spending that money. If you compare it to a cycle of IVF, it's still a lot cheaper.
Okay. Dr. Victor, we've had a message from a patient of yours. Her name is Nolene. She says, wonderful to see and hear you again. You delivered both my children in 2007 and 2008 and helped me through depression. Truly a wonderful doctor.
Oh, awesome. Thank you for the feedback.
So, Dr. Victor, are there any tests that a male partner would do, blood tests that he...
One must not forget, if you sit with a couple in front of you that is struggling to fall pregnant, we do know in about a third of the cases it's a female issue alone. In a third, it's a male issue alone. But in another third, it's a combined problem. So we always send the males, even if they have a child from a previous relationship. I mean, anything could have changed in the meantime. We always send the patients for a semen analysis. It can be done through a normal laboratory. I prefer to send my patients to a fertility clinic to do the semen analysis because they look at a couple of other things that the normal labs don't do. But I think it's very important to exclude the male factor from the word go before you start working on the female, and then you get to a stage where you've been trying for a year and nothing is happening, and then you miss the male factor, which throws a curveball, and then it's something that could have been addressed way earlier on, and you could have helped the patient very earlier on in the process.
Are there any specific tests that you would send the male partner for?
So the semen analysis is basically just to look at the sperm, but if the semen analysis comes back abnormal, then we also test the male hormones. So we also test their LH, FSH, male hormone, their prolactin, their thyroid, to see if it's not maybe a hormonal issue that's causing the abnormal sperm count. So in patients who, for instance, have very low sperm counts, where we think it might be due to early testicular atrophy, where the testis starts dying off earlier, we do test the male hormones as well as their LH and FSH.
Okay.
Also, just to give us an idea of how we will struggle to get sperm to work with if the patient goes to the IVF clinic.
Okay. Should any of the tests that we've spoken about so far be done before my appointment, so that when we come for the appointment, we have the results?
Some doctors might ask the patients to go for that in advance. I prefer to see my patients first. And the reason for that is, as I said, there are so many areas where the problem can lie. So I prefer to first have my examination with my patient, my consultation, and then decide to tailor-make the blood tests that we're going to do. It might be totally prevalent when we do the examination that we're sitting with a fibroid in the cavity, and then the patient spent the $5,000 of blood tests, and we know that it is actually the fibroid that's causing the problem. So I prefer to see my patients first. The other thing is they very often come to us as a referral from a general practitioner, and then they did the blood tests at totally the wrong time of the cycle. And then the patient must repeat everything again. So no, my feeling is first go and see the doctor, first hear what the history is, first work out where the pathology is maybe lying, and then let your doctor decide which tests needs to be done.
Okay. We have a note here from patients. She says, I'm going for an HSG tomorrow and I'm scared. I'm 42 years old. Any tips for patients?
All right, so a hysterosalpingogram is an HSG, and it is done at the radiology department as an alternative to a laparoscopy to see if your fallopian tubes are open. So basically what's going to happen to you tomorrow is you're going to go into the radiology department. They're going to insert a little instrument into the vagina that is the same instrument that we use to do the pap smears. And then we've got a small little guide that we put into the cervix. I always say it looks like a little Christmas tree that we put in there. And then we inject dye through the cannula into the uterus. And while the dye goes into the uterus and through the fallopian tubes, we take x-rays from on top to see if the colorant goes through the tubes. Now, obviously, because the fallopian tubes are so small and pressure is used to inject the colorant, it can be a little bit uncomfortable. So I always give my patients Buscopan to take, which is a smooth muscle relaxant, just to alleviate the pain. And I would recommend maybe take an anti-inflammatory before the time. And as the dye goes through, it's literally a second or two that you're going to experience pain, and then it's all over.
It's over.
Yes. So it's going to give us a good answer if your tubes are open, and it's going to spare you surgery, hopefully. So it's going to be a small price to pay on the long run.
Yeah. Okay. Well, good luck to you, patients. Thanks for that, Dr. Victor. We have another question from Irene. It says, if you are in a negative blood group and your partner, you mentioned antibodies, what does this mean?
Okay, so patients with a negative blood group, if they are in a relationship with a partner that has a positive blood group, when you fall pregnant, your baby will obviously have either your blood group or your husband's or a combination of that. And we won't know what your baby's blood group is until your baby's born. There is some very specialized technology which we do use in patients that struggle with antibodies that we can use to determine the baby's blood group, but we don't do it routinely. So what happens is, say for instance, you are O positive, your husband is O positive and you are O negative. If there is some form of bleeding over the placenta and some of your baby, which might be positives, blood cells, land in your bloodstream, your body might see this as foreign and produce antibodies against that O positive blood group. Now, it's usually not a problem for the pregnancy that you are currently having, but if you build up antibodies, your next pregnancy is usually affected. Now, to prevent these antibodies from forming, we do give the Rh negative mommies who have an Rh positive partner injections during the pregnancy to try and prevent those antibodies from forming. After birth, we then test the baby's blood group, and if the baby has a negative blood group, which is known to the mommy's body, then she doesn't need another injection. But if the baby is a positive, meaning the daddy's blood group, then we give an injection to basically make sure that the mommy does not develop antibodies in a future pregnancy. Now, what can happen in a future pregnancy if you have antibodies is that your body will then see that baby as foreign and the baby's blood cells as foreign and attack it with these antibodies that can go over the placenta. And the babies can then become anemic and even go into cardiac failure. So we try and prevent the antibodies from forming. If the mommy already has antibodies, if she is pregnant, then we follow up the pregnancy with Dopplers to make sure that the baby does not become anemic. They can get intrauterine blood transfusions or then be born earlier so that we can give the baby a blood transfusion if necessary. Now, just a quick word on infertility in patients with Rh antibodies. The latest technology nowadays that can be done at an infertility clinic is where we do IVF and we then take a biopsy of all the embryos and test their blood group. And then we just put the embryos back of mommy's blood group so that it's not foreign to the mommy. So we currently have a patient in our hospital that had a miscarriage at 22 weeks due to this, and she's now going to go through this whole process to get IVF done, biopsy sampling with pre-genetic implantation studies to see which of the embryos might be rejected, and then those we don't put back, and then the babies who have the mommy's blood group can then be put back, and that will just give her a bigger chance of having a live born.
Okay. Well, it's good news that there is an option for patients who are in that position.
Yes, it's luckily something that we don't see very often anymore because we have the inoculations in place that gets done antenatally and around birth, but every now and again somebody might fall through and build up antibodies.
Okay. We have a question here from Vatiswa. She says, I don't have both tubes. Is there anything you can help me with?
Okay, Vatiswa, unfortunately, you do need your tubes to fall pregnant naturally. If both your tubes are blocked or removed due to previous surgery, your only option of falling pregnant is basically in vitro fertilization. In vitro fertilization, they bypass the fallopian tubes, they collect the eggs. In the clinic, they then fertilize the eggs and they put the fertilized embryo back into your uterus. So they can bypass the tubes, but unfortunately it means in vitro fertilization.
Okay. Then we have another question from Shireen. She says she has PCOS. Is Ovvance good for it?
Yes, so Ovvance, or just quickly to go one step back, polycystic ovarian syndrome is basically where you have an imbalance in your hormones and your LH-FS ratio in your brain is not correct. And that causes your ovaries to make a lot of small little follicles which don't ovulate. These patients very often have very long menstruations, very long cycles without ovulation. And their male hormones are increased. Now, the latest studies show that anything that contains inositol and alpha lipoic acid will correct the ratio by decreasing your insulin. Now, these patients tend to have insulin resistance as well. So if you go and do their fasting insulin and glucose, which is one of those 5 hormonal systems, one will see that their insulin is high, and Ovvance is one of those products that will help you stabilize your insulin levels. As soon as the insulin comes down, the male hormone goes down, and the LH-FSH ratio can be corrected. That, in combination with what is very important, is weight loss. Studies show that if a patient loses about 10% of her body weight, she might even start ovulating spontaneously without needing help. So a product will help, yes, but you'll have to also bring your part by losing a little bit of weight.
Okay. So can I and should I prepare for the fertility assessment consultation? Like, for example, what is the case for sex beforehand or showering before the appointment and so on?
What we always ask the patients to do is to bring along with them a fertility diary. So we all have these new cell phone apps that we can put our ovulation tracking on. So if a patient comes to see us, it's always a big benefit if they can bring us their ovulation or their menstruation calendar, so that we can just get a good idea of what the cycle's been like the last couple of months or years, because that will give us a good idea of what we're sitting with. And then, like for any other gynecological examination, it's good not to have intercourse a day or two before the examination, because that might influence the pap smear. And then, of course, maybe a good shower before the time, just so that neither you or the doctor feels uncomfortable.
Okay. And can any doctor do this assessment?
Any gynecologist can do the assessment, especially, obviously, doctors who are more interested in infertility treatment and fertility assessments. A general practitioner can, unfortunately, most of the time not really evaluate a transvaginal ultrasound. So it is the best to get this done by a gynecologist rather than a general practitioner. But yes, just do your homework before you go and see a gynecologist, and maybe see if they are actually interested in infertility, because it's gonna be, you're gonna get more worth for your rand.
Okay. And should my partner attend the appointment with me?
No, there's no need. There's no need for him to come along. The only thing is, we will obviously send him for a semen analysis. I don't even have to see him before the time. If the semen analysis comes back abnormal, then he might be evaluated by a urologist. But there's no need for him to come along for the fertility assessment to the gynecologist, no.
Okay. And what role does folic acid play in my fertility assessment?
So South Africa sits with a huge problem with a lack of folic acid, the mineral in our soil. And we do know that a lot of our foods that we eat are fortified with folic acid, like, for instance, our mazes, our bread, our milk, all our staple foods, because of the reason that we struggle with folic acid. Now, folic acid plays a huge role in the brain and spine development of a baby. So especially in the first trimester of pregnancy. So if you lack folic acid, your baby can be born with an open spinal defect like spina bifida, or open brain defect, or even brain defects. And if you fall pregnant on folic acid, you actually decrease your risk of falling pregnant with an abnormal baby by 50%. So it plays a huge role. The other thing is, patients don't realize that they usually go onto folic acid the moment they find out that they're pregnant. But it takes 3 months for your liver to build up a good enough level of folic acid to actually protect the baby. So it is the best to go onto a folic acid supplement at least 3 months before you start trying. Some of the oral contraceptive pills also now have folic acid added to them, especially for those mommies who want to go off the pill and try and conceive, especially for that reason, to get the folic acid levels up before they conceive.
Okay. We have a question from Nolene. She says, if one has been on the injection, the contraceptive injection, for more than 10 years, how long would it take to conceive after she stops the injection?
Now, first of all, one should not be on the injection for that long, Nolene, because the progesterone-only injection affects your estrogen levels because it counteracts your estrogen, and that's actually exactly the way it works. But if you are on one of those injections, you need to give your body a break every 3 years. So you can stay on the injection for 3 years, give it a break for a while, go back on the injection for 3 years, give it a break, just so that your body's bone density does not decrease. I've seen osteoporosis in ladies in their 20s due to long-term use of the injection. Now, if you are on the injection, and even if you just had one injection, it can postpone your fertility with up to a year. So if you've been on the injection for quite long and you stop it, it might sometimes take a year or two just for your periods to come back. And if you then sit with underlying other pathology, then it might even take longer. So I wouldn't recommend such a long-term contraceptive for a patient that's planning on falling pregnant within 5 years. And do give your body breaks in between. But what your doctor can do is to try and give you estrogen-containing contraceptives just for a while, to try and just get a cycle back. So by lifting your estrogen levels, we can sort of counteract the progesterone.
Okay. And how long a break do you recommend between injections?
A year. So 3 years on, 1 year off. 3 years on, 1 year off.
Yeah, it's quite a challenge because when you find the contraceptive method you like that works for your body,
exactly,
it can be difficult
I think that is why the intrauterine systems became so popular, because it gives you the same benefit than the injection, but it's a totally reversible form within a month. So the same benefits that you're going to get from your injectable contraceptive, you'll get from your intrauterine device, a lot lower doses. And the moment I remove that intrauterine device, like for instance the Mirena, the next month you can fall pregnant again. Because the EPO preparations, you have to give a very large bolus of hormone to last for 3 months, where the intrauterine device is small little doses that's secreted every day. So you don't postpone your fertility with having an excellent contraceptive on board.
Yeah. We've had a message from Tandekile. Tandekile, if you can tell us where you are based or send us a message, then we can put you in touch with Dr. Victor, or you can come to our clinic in Cape Town if you're based here. She says, I had a stillborn in 2012 and a miscarriage in 2013. Now I'm struggling to get pregnant. Any thoughts on whether or not she should see a fertility specialist, Dr. Victor?
Yeah. I would definitely recommend that you go and see a specialist, because there must have been some reason for the stillborn, and of the fact that you're now struggling to fall pregnant after having the miscarriage. We do see that a lot of patients, after having a stillbirth or even a natural birth and evacuation that could have been done for the miscarriage, can get infection in the uterine cavity easily that can block your tubes. But a patient like you should actually get a full workup to see if the tubes are open, what is the reason, why am I losing these babies? So yes, try and get to see somebody before you try and fall pregnant any further. Don't fall pregnant now and then the problem recurs. So first get to see somebody before you might have another issue. Definitely.
All right. So we have a final question, Dr. Victor. How do fertility assessments differ, if they differ at all, for same-sex couples?
Okay, so if we look at same-sex couples, obviously they will need some form of infertility treatment at an infertility clinic, either donor sperm or donor eggs for that instance. If I just focus on the female side, for us it is important to evaluate both the ladies to see who the best candidate would be to carry a pregnancy. So say for instance we have a couple of 20 and 35, we will obviously focus on the 20-year-old to rather carry the pregnancy because her chances of having a better outcome pregnancy will be better. But say for instance she has blocked tubes, then the 35-year-old will be the better one. So it is important to evaluate both the females to see which would be the one, and unfortunately they will both need the whole workup to see, because they will need donor sperm, which can only be done via an infertility clinic. And then in males, they will obviously need surrogates to carry a pregnancy and or a donor oocyte. So for them, it's not as important. They just both need sperm analysis or semen analysis, but the females both need to go through the whole fertility assessment to make sure which is the better candidate for the treatment.
Okay. All right. We have a follow-up question from patients who asked earlier. She's having a HSG tomorrow morning. She says, what happens if the results from an HSG shows that the tubes are blocked, and she's 42?
Okay, so first of all, at the age of 42, one's fertility is already decreased. So one must just make sure what your anti-Malarian hormone looks like to see if you are a candidate for normal conception. If the tubes are blocked, then you are going to need infertility treatment in any case. But if your tubes are open, we must still make sure that they are fully functional, because they might be open, but they might be dilated and not working properly. So I would, at the age of 42, evaluate a patient properly as if she is going to go for IVF, because the age factor, and unfortunately we do know that after 40 your fertility decreases dramatically. But if the tubes are blocked, for instance, yes, IVF. If the tubes are dilated and you have fluid in the tubes, then those tubes actually needs to be blocked before you can get infertility treatment. So it all depends on what your fertility status is. Do you still have a good enough anti-Malarian hormone count? And if the tubes are open or not, and what they look like. Okay. And I hope those tests were done before they sent you for the hysterosalpingogram.
Yeah. All right, Dr. Victor, do you have any final thoughts for people that are considering coming in for a fertility assessment?
I think, speaking from our own heart, I think it's very important for ladies who, we do know that we tend to marry at an older age nowadays. Patients tend to have their children at an older age. And one of the things that I would really like to recommend to younger patients who are not in a relationship yet, who are only planning to establish their career and getting married later, is to maybe do oocyte banking, to make sure that one day, if you meet Mr. Right at the age of 42 and you want a baby of your own genetics, so that you maybe have your own eggs on ice somewhere at a fertility clinic. That's the one thing I would like to definitely recommend the younger girls to think about that, and then rather seek help earlier than too late. Because if you land up at us at the age of 35, your chances of having a successful pregnancy is way better than it would be at the age of 45 or when you're already menopausal. Just on that topic, you can of course still have a baby if you're menopausal via help through the infertility clinic, but rather present earlier if you think that something's wrong than waiting too long.
Okay. All right. Well, Dr. Victor, thank you so much for joining us, and we've learned so much from you, and it's everything you've said has given us pause to get to our fertility assessments and really not leave it until too long. It's always easy to put off going to a gynecologist, but it must be done.
Yes, it must be done, and rather sooner than later. And as I say, we can maybe spare you IVF treatment if you go for that assessment and see that it's maybe something that can be treated very easily, and then you can have your bundle of joy in your arms before you know it.
Yeah. Okay. Well, thank you to everyone who's joined us today. We'll have Dr. Victor's contact details at the end of one of these videos and in the post. We're so glad that you can come along and ask questions and learn from some of our experts. Our next Q&A will be with, or episode of Fertility Diaries will be with our social worker, a clinical social worker on the 30th of April at 11 a.m. We'll also be doing interviews with egg donation and sperm donation specialists and other interesting things that are fertility related. Once again, thank you for joining us, and enjoy the rest of your day. Goodbye.
Thank you, Kenny. Thank you. Bye-bye.